همش
Good morning. Thanks for letting me see your face, Latasha.
Good morning. You're welcome.
Good morning, everyone.
Morning.
See some sleepy faces. I feel ya.
Morning.
I have some announcements to make, a little bit of housekeeping before we get started on our lecture this morning. Just a reminder that our test review is today after class. We're going to end class at about 10:45, 10:50, like normal. And then we will go into our test review. So you should have gotten that message email from Ms. Cochran and Ms. Rogers. The test had a very good average. Most of the students did really well. We are going to have all of you together because we don't anticipate nearly the questions that we had before, but you're certainly welcome to ask whatever you need. And folks, please have your download your forms if you haven't already. You'll need to download your forms before we get started. We don't want anyone held up while someone's trying to find a form. Also, Ms. Tardo Green is asking that you guys see her next Thursday after class, what would normally be a lab time. She has some feedback that she wants to give the group holistically because she's saying the same thing to so many different students. And she wants to just holistically give you guys some feedback about the second hour of lab. Okay. Is anybody having trouble accessing their information on Canvas for Unit 5? Everybody have what you need? No issues. Okay, very good. So we are going to launch into class, and I need to share the screen with you guys. Here we go. So if does anybody have any questions before we get started? Okay. What I'd like to do is, as we go through a certain topic, I like to go through and finish that topic, and then I'll stop and ask if anybody has any questions. So with a class of however many of you that are going to attend, at least 30 to 35, it might be difficult to hear the questions for me. You can certainly put them in the chat, post your questions there, and then after, to help you remember what they are, and then after class, I'll have I can go back and make sure I address all of those. You can use your discussion board. I will go back and address questions there as well. But the chat should be recorded with this lecture for future reference. So we're going to go ahead and get started. This is Unit 5. We're doing reproductive health. And we are going to discuss today breast health. Tomorrow we're going to focus on, well, not tomorrow. Tomorrow's a holiday. So next Thursday, we are going to be doing gynecological health and urinary incontinence. Hopefully we can get through both. The following day, we'll be focusing on men's health, and that's a fairly short, relatively short, and we're going to try to get through sexually transmitted infections. Our final topic is elderly adult. That is fairly short, and my hope is that we will have time to have our last day as a review. So we'll get started today on breast disorders and hopefully get through as much as we can. Noah,
do we not have class tomorrow since you said it's a holiday?
We are not on our schedule. We do not have class for tomorrow. I'm available, but when it's not on the schedule, there's a chance that 41 students could have booked themselves for something else. If you guys want to get together in your own personal chat and decide that you want to have class, I would have to have a very large majority of you agree, and I would be happy to do so. So that's something you guys can do on your own. I'm flexible. I'm going to be stuck here at home, so I would be happy to have class with you. But on the schedule, lots of people may have booked themselves for work or other appointments. Just let me know. Somebody can be a spokesperson and let me know. But it would have to be like 80% of the class would agree. Okay, this will be recorded. All of these will be recorded. So just have that reassurance. Any other questions?
No, thank you. I got it.
Okay, no problem. Glad you asked. Okay, so breast disorders, our class objectives are going to be should be familiar to you. We want to understand risk factors and screening recommendations. A lot of what we do is teaching. What does it look like? Remember the nursing process, we do assessments. So we're looking for the clinical manifestations, diagnostic studies. We're going to talk about the medications and treatments, and pre and post procedure and surgical care. What is our role in taking care of them, and what do we need to teach them once they're out of our care? So let's do a review of what we did for our homework. I'd love for you guys to chime in. Please, I'm going to wait for you to chime in. So for number one, which one of these is breast conservation therapy?
Jay,
Good, Jay, that's lumpectomy. And these, you'll need to get used to these terms because they'll be used interchangeably. Which one is an aggressive form of breast disease with poor prognosis?
E.
E, inflammatory, right. It's not common, but it's very dangerous and unfortunately tends to affect younger women. The most common benign tumor in women during reproductive years.
A.
A is fibroadenoma, good. 4, dimpling orange peel. What is that?
D. D is in dog.
D is in, and that's called peau d'orange. I don't speak French, but that's how you pronounce that. Usually benign condition of breast enlargement in men.
B as in boy.
Good, that's gynecomastia. Important prognostic factor in early stage breast cancer.
Ah,
I, nodal status, excellent. Benign breast problem with premenstrual fullness and tenderness.
G,
Which
G.
one was that? G. That
G.
should be fibrocystic. Good. Okay. And number 8, most effective screening tool for breast cancer.
L.
L is mammography. Number 9, abnormal accumulation of protein fluid in the subcu tissue.
C.
C is lymphedema. And 10, genetic mutations associated with higher risk of breast cancer.
H.
H, BRCA1, BRCA2, excellent. 11, early non-invasive form of breast cancer.
F.
F, and that is ductal carcinoma in situ. Sorry, my picture of you guys is covering up my good. Ductal carcinoma in situ. Requires excision because this is more likely to be malignant.
A, complex cyst.
A, no.
No, K.
Fibroadenoma.
K,
Okay, very good. Complexes. I'm sorry, I have hearing issues. Okay, so just so you all know, you have the right answers to those. You do need to know your terminology. Make sure you're familiar with those, what those mean. So in order for us to understand the clinical manifestations of what a breast disease looks like, we need to know what normal breasts look like. So just an overview of normal breast. It is very normal for asymmetry. Most women will tell you they're lopsided. They can have dark versus pink areoles. It just depends on skin pigmentation. A venous pattern can be very normal. Some women have very translucent skin. what we want to see is that it's the same on both sides and that it's always looked that way as long as the female has had breasts. Changes in venous pattern can occur when a woman is pregnant and when she is breastfeeding, especially when her milk first comes in. That's to be expected, but if there's no type of pregnancy, hormonal changes, then we should expect the venous pattern to look the same on both sides and be consistent. The same with color. Color should look, most women don't sunbathe their breasts, so their color could be a little lighter, but what we're looking for is uniform and matching. So we want to see uniform color on both sides. We also want to see uniform color on the whole breast. If you have a darkened area, a patch of redness or a shading that's different from any place else, that just needs to be investigated. So consistency. Nipple inversion, one or both. I have a little asterisk beside this because this can be normal. Some women have inverted nipples. Some have one side that's inverted, but as they developed breasts, that's something that they've always had. Some women have surgery to have their nipples reversed if they've had nipple inversion. When this occurs, when someone who has never had nipple inversion and all of a sudden they're noticing that their nipple is pulling inward, that's an issue. That's a change in their baseline. So while it's normal for some women, it's about what their baseline is. Nipple discharge, same story. Some women will have nipple discharge during menses. Maybe they have an underlying condition like fibrocystic or some type of hyperplasia that will cause some nipple discharge. Again, we're looking for something unusual that deviates from their baseline. Most types of nipple discharge will be investigated by the female. We encourage that. Once that's investigated, then they will realize what their new baseline is. Discharge can be put on a slide and it can be inspected for abnormal cells. Montgomery tubercles are sebaceous glands. These are the little bumps that some women will see around their breast. Sometimes they're there, sometimes they're not. They're perfectly normal. Skin texture should be smooth. You don't want the orange peel. You don't want thickening. That needs to be investigated. Again, we want to see what that person's baseline would look like. Hair on the breast should be like a downy or hardly noticeable. What you would expect on the face, usually the cheek area. Sometimes as women get older, they get more hair around their areola and it's more wiry and coarse, but that's part of the aging process. It can also be common with women with darker skin and darker hair. So is there any question on what's normal breasts look like? Okay, that will help us understand what's abnormal. So we're going to launch into benign breast disorders. We're going to talk about 3 that are not considered cancerous and 2 that are precancerous. These are benign disorders. So the first of these are your breast cysts. These are very, very common and they're considered non-proliferative, which just means they don't have an overgrowth or abundance of cells. Not a lot of cellular division. Most of these don't increase cancer risks. If you'll see the 3 pictures, that's how we can tell if it's cysts. Ultrasounds show these up best. The fluid field is nice and black. You see the age group, it peaks at the perimenopausal area around 50 to 55. This is when a lot of women will have more issues with cysts. The simple is the picture. It's you've got good boundaries, nice clear fluid inside, very benign. The only issues you would have with a cyst to treat them is if they would become large and they would be uncomfortable. Women aren't going to walk around with a lot of discomfort, so they may go through aspiration if they're very uncomfortable. Complicated cyst is the top right cyst. You can barely see that it looks a little cloudier in the center with that fluid. So complicated is it might have a little bit of debris. If it's not that nice black clear, you may have a practitioner want to draw some fluid out to rule out any malignancy. These are usually benign. Complex cysts, if you look at the lower right hand, you can see what looks like almost a really dense sludge right in the middle of that cyst. So those are more concerning. These are more likely to be malignant, and they will probably excise the whole cyst and look at the boundaries and make sure that this is not something to worry about. That patient may be followed more closely in the future. Fibrocystic condition, we call this condition because this is something that usually continues or something that a woman has to deal with. Most frequently women 20s to 50s. It does get more common once we hit 35. And what you see is one or more palpable lumps, and these almost are like a very small cluster of grapes. So that's how they show up in the breast. They're much smaller, of course. They are well delineated, which means you can feel the boundaries well, and they're freely movable. So that's something that's characteristic of benign disease. These are freely movable, like little marbles rolling around in the breast. The most important thing to remember about fibrocystic condition, how we differentiate it from the others, is that it's cyclic pain and tenderness. That means it comes with a menses cycle. So if there's something, some of you guys have amazing tricks to remember. If I'm going to share my tricks, as corny as they may be, you can use them or not. But I changed the word of fibrocystic and I call it fibrocyclic. That's not a real word, but if you think fibrocystic, fibrocyclic, that's how you can remember that fibrocystic is the one that is a cyclic pain. As we start our menses just a few days before, the breasts start getting very tender and uncomfortable. Classic fibrocystic condition. Sometimes they can have a nipple discharge, and this is the color you can see. Pretty broad spectrum between milky, watery, yellow, and green. It can be aspirated. Usually, they'll do an ultrasound. They'll do an ultrasound of the discomfort, especially in younger women. They'll see that it's fluid filled, and they'll see the clusters. They'll see the pattern of happening with menses. Very easy to understand what's going on here. If they're more uncomfortable, they can be aspirated. And most doctors, if they're going to aspirate the fluid, they're going to take a look at it and put it under slide. Sometimes the mammograms, especially with younger women, they don't show these up very well. Okay, we see dense breast. So that's fibrocystic condition. What do we do about it? Most of the time we handle this with very conservative measures. Okay, so that's where we encourage a supportive bra. Some women find a supportive bra more uncomfortable. So basically whatever makes you comfortable. Supportive bras tend to help most women, but if it's better for you not to wear a bra at all, then don't. Mild analgesics, Tylenol, decreasing the sodium, the caffeine, things that could cause fluid retention, decrease that, and especially during the weeks leading up to your menses or the days. Cold, heat, whatever's most comfortable. These are all conservative approaches. Some women are so uncomfortable that they will ask for something more aggressive. These aren't working for me, these conservative measures. So we will launch into hormonal manipulation. That will look like OCPs, oral contraceptive pills. What these do, they use a lighter dose. They start out with the lightest. And if we can lighten the period, it will shorten the period, and will shorten the amount of discomfort. Okay, so this is associated with your menses. Make that smaller, this pain will be smaller. SERMs, this is a selective estrogen receptor modulators. You're going to hear a lot about those. These correct luteal insufficiency. They're basically will put you in premature menopause. The most common of these drugs are tamoxifen and raloxifene. These are SERMs. You're going to hear these a lot, but these could be used if the oral contraceptives aren't effective and the discomfort. So they'll keep moving up in the hormonal spectrum until we get something that works. These women need to stress follow-up with their physician. They need to do breast self-exams, probably religiously. It's not that fibrocystic condition puts them more at risk. It's that if they do develop a lump, something unusual, they really need to know their breast to understand what their normal lumps are versus something new. Do know that if a woman goes into menopause and they try the oral contraceptives, if they go on hormone replacement therapy, if menopausal women go on hormone replacement therapy, they can start those fibrocystic discomfort again. Okay, you're introducing estrogen, which is causing that discomfort in the first place. So that's something that they'll need to think about. Which is the worst of two evils? The hot flushes and the symptoms of menopause, or the tender breasts, which is up for that female to decide. So fibrocystic condition, what it looks like and how to manage it. Fibroadenomas. That's another very common benign lesion, and this is most common during reproductive years. We see this with younger girls. So this is a solid mass as opposed to the fluid-filled mass of the cyst and fibrocystic. It's glandular and fibrous. It feels rubbery. These are also unattached to its surrounding tissue, which means it can roll around freely like a marble. Not sure why it's caused. Most people think it's estrogen, increased estrogen sensitivity. Breast tissue is just more sensitive to that, which is why it surges in the late teens all the way up to 30. So these typically women who have fibroadenomas will have more than one. Their breasts just grow these solid benign tumors. They can be very scary for these women. They tend to be more common in African Americans, but they're very common in Caucasians and Hispanics as well. When a woman has a solid lump in her breast, they need to go and have it investigated, and we'll do what they call a triple test. They will go to the doctor, have it palpated, they'll look at it under ultrasound, and they will likely have it biopsied. Physicians are so familiar with what this looks like under ultrasound, they may reassure the female and said, I know exactly what this is. This is a fibroadenoma. Let's just watch it closely. It does produce a lot of anxiety. So some women will say, I wanted biopsies. I want to know exactly what it is. And they'll biopsy it, and usually it'll be fine. The only way to treat fibroadenomas or remove them is either under surgical excision or cryoablation, cryotherapy, which is freezing. So their radiation will not work, hormone therapy will not work, chemotherapy will not work. The only way to treat these is to remove them, and that's something you'll need to remember. Okay. I like this little cartoon that shows on the left the fibrocystic changes, and then on the right the fibroadenomas. And you can see them taking a chunk out for the biopsy, but again, it needs to be surgically removed. Okay. So before we go into precancerous lesions, any questions on the cysts, the fibroadenoma? Okay. So precancerous lesions, there are two main ones we're going to talk about. What goes into so many different things. There's just too much for us to be concerned about. Atypical ductal hyperplasia is a very common disorder, and it is considered precancerous because we have that proliferation or overgrowth or hypergrowth of cells. So these will be watched very closely by the physician. It increases the risk by 3 to 4. Sometimes there are calcifications in the breast that looks like little white spots or dots on the breast. And if it's associated with calcifications, they'll watch it even more closely. If it's a multifocal lesion, that means that it's more than one duct that's affected by hyperplasia. That's even more concerning, okay? Even more concerning if it has multifocal or more than one place in the breast. So they may have more aggressive recommendations, which we'll see at the bottom. Another precancerous lesion is lobular carcinoma in situ, and it's abbreviated LCIS. So unlike ductal carcinoma in situ, lobular is considered a precancer. Okay, they say this is not really cancer, but we're going to call it cancer. That's what we're going to name it. It's confusing. The worrisome thing about this is that it's usually diagnosed when women are younger, in menopause. And while it's not considered cancer because it can sit in the duct forever, it can eventually start to metastasize. So it's increased by 8 to 10 times. So these are both precancerous lesions and are markers, if you will. They consider these markers. And there are several ways this can be handled. It really depends on comorbidities of the female, her past medical history, her past history of cancer within her family. So they can treat these just by close observation. They may start them on a SERM, which is tamoxifen or raloxifene, or we could do a prophylactic mastectomy on these females. It just depends on all the other risks involved. Breast cancer. So 1 in 8, that is the number, 1 in 8 will develop over a lifetime. So the average female has a 12% chance of developing breast cancer in her lifetime. Early recognition, look at our 5-year survival rate. It's phenomenal with just localized early recognition. Once the regional nodes, and when we're talking regional, we're talking about lymph nodes within the breast and axilla area. You still have an 83, almost 84% chance of a 5-year survival rate. If it becomes a metastatic disease, it starts to go to the bone, the brain, anywhere else, that's when we have a 21% 5-year survival rate. So it drops drastically, and our main job is to get people to get screened and catch it early. So common sites, you'll see the picture on the right. You'll see 50% of the cancers are in the upper outer quadrant, close to the axillary area. That's the most common site of breast cancer. Common sites of metastasis. We'll see brain, bone. See my notes here. Lymph nodes, of course, because there's a ton of lymph nodes in the area, lung and liver. So we have brain, bone, lung, and liver. It spreads through the lymphatic tissue and through blood flow. So lymphs, like most cancers. Early detection, of course, that's no news to you. The best thing we can do as RNs is teach screening guidelines, let people know what their risk factors are. We need to know them and teach them, because if you have significant risk factors, you need to start that screening process earlier. And breast health exams. We want to encourage women starting at the age of 20 to have self-breast exams. Now this slide, you do not have to memorize this slide. I just wanted to give you guys an indication of the different types, what their significance is. Like ductal carcinoma in situ, that is considered cancer, but it's considered stage 0. Most cases are infiltrating ductal carcinoma. That's the most common. You'll see 75% of all cases. But the most important thing to understand here is that the infiltrating ductal carcinoma is the most common. And although inflammatory breast cancer is minimal, I want you to see what it looks like, how aggressive it is. What does it appear? It looks like mastitis. So that is important. You need to know what that looks like. Not common, but it happens in younger women. It could look like a spider bite. It could look like cellulitis. It could look like mastitis with a woman who's breastfeeding. So it's not to be confused with those and needs to be investigated. Very serious. Men can get breast cancer. It's only 1.3% of all cases. That number is creeping up a little. It used to be about 1%. So men do get breast cancer, Their survival rate is not as good as women. It's not because of their tissue type. It's because they don't expect to get breast cancer. So they could have a lump that's growing. They could have symptoms. They wouldn't know what it is, and they wouldn't know to go and have it checked out. So we need to teach men the same. If you have any abnormal lumps, bumps, you need to get it checked out. 1 in 100 will get breast cancer. So what do we do about it? Well, we need to understand the risk factors. And folks, I forgot to tell you, as I was going through and reviewing my notes, I recognized that all my tables and charts were off. So I went through this slide, I started changing them. And when I got to the GYN lecture, I realized that I brought home the wrong set of books. I brought home the 8th edition instead of my 9th. So I reversed all my slides back to the 8th. If these tables do not match your edition, there is a risk factor table in this chart. I mean, in this chapter, chapter 70, you'll just have to figure out which one it is. I have not been back to my office to pick up the right edition, so I apologize. Risk factors, you need to look at, when I point out tables and charts to you folks, you need to take a look at them. Okay, it's very important. You're going to probably see them again. So you need to understand what your risk factors are. This was part of your homework, so you should have looked at your chart. And you need to understand which are most significant and which are lesser significant. So the higher risk factors have to do with genetics, whether you've had BRCA1, BRCA2, whether you've had family members, especially close relatives, first-degree relatives. If you've had 2 first-degree, that's a big deal. If you've had cancer yourself, if you've had radiation, those are the more common. Some of the less common have to do with hormones. Cultural variance, there is a higher incidence among certain cultures. The book gives you a variety of which ones we know that's higher in the Jewish culture. We know that Euro-Americans have a increased incidence over 40. So we do see a pattern, and what all that's telling us is that there is a genetic mapping to breast cancer, and we're learning more and more about that every year. You don't need to know what those are, but you just need to know that cultural variances do exist, and it's about genetics. Sometimes it's about lifestyle, but we're really looking into the genetics. So primary prevention, how do we avoid it? We know carcinogens are out there, and a lot of your generation, luckily, are changing their lifestyle, their diets, the foods they eat, to decrease the amount of toxins they expose themselves to. So you need to know what those carcinogens are and try to avoid them. I think women, one of the concerns these days is deodorant, antiperspirant, the aluminum that is there. You'll see now they're showing a relationship between that and breast cancer. So you're seeing aluminum-free deodorants out there now. So these are the changes we're making over time to identify those. This picture shows that someone's standing on a scale. Obesity, alcohol, these are some things that they think are linked to breast cancer. So avoid carcinogens, make those lifestyle changes. Secondary prevention is when we get into your detection and screening. The earliest you detect it, of course, the better the outcome. So let's talk about that early detection and screening. This is for average risk asymptomatic individuals. That's very important for you guys to hear. Average risk. So for the average risk person with no symptoms, the recommendation is that starting at the age of 20 through about 40, you have a CBE clinical breast exam every 3 years. And they recommend self-breast exams every month. Okay, and this shows some tips on self-breast exams every month. That was part of your homework. What do we teach women about self-breast exams? We want them to understand that they need to use a pattern. It doesn't matter if it's circular, if it's up and down, if it's starting on the outside working in, as long as they use a methodic pattern to cover all the breast tissue, they can use whatever works best for them. They also, women of menses, they need to do this a week after their menses. that's when their breasts are the least engorged and the least tender, a week after their period, so they can mark it on their calendar. If you're menopausal, pick a day, any day out of the month. They can do it the first, they can do it the last day, but just pick a day that they can be systematic and methodical. Older than 40, this is when we introduce clinical breast exams yearly. Our risks get higher as we get older. So every year we need to have a clinical breast exam. Again, self-breast exams monthly, and then mammograms are yearly. Now, what I have on your slide is every year or every other year. The government, US government, is trying to get us to go every other year. They feel like yearly mammograms are not necessary. Canada is on an every other year schedule, but we still, most insurances still promote and cover mammograms every year. And there are a lot of women out there that said, I missed my mammogram 1 year and now I have breast cancer. Don't ever miss your mammogram. So far, we're still supporting that. So with self-breast exams and mammogram, you'll need to remember these things. How frequently, we discussed that. When's the best time? Pre-procedure instructions and post-procedure. What do you teach someone about pre-procedure mammogram? We basically don't want them to have any powders, lotions, or deodorant on. So there are some metals, as we discussed in Unit 1, in lotions and deodorants, and that may interfere with the digital x-rays. Post-procedure instructions, they can be uncomfortable. Mammogram squeezes you pretty tight, and if a female needs that, she will just need to take Advil or Tylenol, whatever, for the comfort. There is a breast exam link here that you guys should click on and go into, and just give some instructions on how to do self-breast exams. Now we're talking about high risk folks, not your average risk. When someone has high risk, they may have that 4 times higher risk because of hyperplasia. They might have lobular carcinoma in situ. Now they're high risk, they're surveillance. Maybe they have 2 family members, first degree family members that are that have had cancer. They're BRCA1, BRCA2. This is a whole new ball game. Now we're in high risk, we're under what we call surveillance mode. The biggest concepts here are they have more frequent screening, they start earlier, and we add an MRI, okay? So depending on their age, we recommend under the age of 39 that you have a clinical breast exam every 3 years. Well, these women might have one every year. Mammograms starting at 40, maybe they start at 35 or 30. Mammograms yearly, maybe they have them every 6 months, okay? Maybe they have an MRI every other year just to make sure that things, because that has, we can take a different look. So more frequent screening, earlier, add the MRI. We may throw in chemo prevention. We've already talked about this. Add tamoxifen or raloxifene. Women are at high risk. They want to start taking tamoxifen right away because that will decrease their chances of it developing into breast cancer. You know folks that have already had prophylactic mastectomies. We know people in the media because they were positive for BRCA1 and BRCA2. So people that are positive for BRCA1 and BRCA2, their incidence goes up, I believe, to 18%. So it's not a huge amount that we would think of, but it's significant enough for some of these women. Do know that while most breast tissue is removed for mastectomies, there's never 100% removal of breast tissue. So they still need to be covered very closely. So in parentheses, I have all the reasons why someone would be high risk and need to be under surveillance mode, okay? Prophylactic mastectomy, I have that there twice for some reason. Sorry about that. Just remember, some folks are not a candidate for the medications. Some folks may not be a candidate for the surgery. So tell me what you know about tamoxifen that may, somebody tell me that may make them not a candidate. What do you think? Anyone?
Is pregnancy one?
That is a good one, actually. Not what I was thinking of, but that's definitely valid. You would not want to take either of these drugs if you were pregnant or you were wanting to become pregnant. So thank you for that. That wasn't even in my brain, but that was definitely worth mentioning. These are hormone-like substances. What do we know about what is a risk factor when we take hormone-like substances? It's a side effect of birth control or hormonal replacement therapy or a complication.
Osteoporosis?
That is osteoporosis, softening of the bone, yes.
Are you going towards blood clots?
I am, thank
Okay.
you. Yes, I am, good job. Whenever you take anything that's an estrogen blocker, an estrogen replacement or an estrogen blocker, they behave like estrogens, so you have the risk of blood clots. So if you have if you're treating someone, you have someone with a family history, BRCA1, any of these, and they choose chemo, they are considering chemo prevention, we need to look at their history very carefully and make sure that they don't have a history of strokes or a history of blood clots. They would not be good candidates for the medication. Does that make sense? And if you have a prophylactic mastectomy, if you have comorbidities and you heal poorly, you're a brittle diabetic, you may not be a good candidate for the surgery. So you have to consider risks versus benefits with these strategies. That's why there are so many options to treat breast disease and breast cancer. Okay. Does anybody have any questions about risk factors, things we've talked about so far up to this point?
Can you just explain how the SERMs work one more time?
SERMs are just selective estrogen reuptake modulators. They basically fool the receptors. They fool the receptors into thinking that they're actually estrogen. So they modulate the amount of estrogen that can be actually taken up by particular cells. Okay, especially the abnormal and the cancerous cells. Does that make sense?
And so how is that helping exactly?
If you'll hold on, when we get talk about breast cancer, we talk about the estrogen receptor, the hormone receptor positive, that'll answer your question, okay?
Thank you.
If it doesn't, you get back to me, okay? And that's Travis, right?
It is.
Okay. If I don't answer your question, let me know.
They said
Okay.
when it comes to men, does family history also play a role in breast cancer?
It does. Yes, it does. If you have a male who has, you know, 2 people in their family that have had breast cancer, I mean, the reason why is because it's probably more genetic. There's a chance they have that BRCA1, BRCA2, and they found more genetic abnormalities to add to the BRCA1, BRCA2. There's a chance that that is carried to the X chromosome in the male. So yes, it is. They have to look at their risk factors as well. That was a really good question. Thank you.
Ms. Alder, I have a quick question.
Sure.
When you were talking about the precancerous lesions and you were talking about the LCIS, you said they sit in the ducts for a while and then afterwards you said something else. You said that do they metastasize?
What's so challenging, and I have researched and researched and researched to try to help you guys understand and help me understand, why is LCIS considered not cancer while DCIS is considered cancer? They're both in situ carcinomas, and I still don't have a good, clear answer for you. It's very detailed cellular mapping, which says this meets criteria and this one doesn't. But basically what I was saying was the carcinoma in situ are a cluster of abnormal, what they call cancerous cells that sit in the duct and they don't metastasize. So they call it non-cancerous because it doesn't spread. However, you have an 8 to 10 chance of that becoming something that will become invasive and spread and become lobular cancer. So that's what the literature says. While there's a good chance it'll just sit there and never ever spread, you have an 8 times chance of having cancer because of it just sitting there. Does that help?
Yes, ma'am. Thank you so
Okay.
much.
I struggle with it, to be honest with you. Okay, so we're going to move on to assessment. We want to talk with women that come in. When they come in for a physical, we should be assessing those risk factors. Usually there's a questionnaire, a very extensive questionnaire that they have to fill out, discuss their risk factors, their family history. They even want to know all the questions about hormones. When was your first child? Did you ever breastfeed? Did you ever take birth control? All those things. They also want to know about the history of a breast mass. Have you ever had one? Do you struggle? Do you have fibrocystic? Do you have any lumps? Then they will assess the patient, and they usually assess if the one breast has nothing, they'll assess the normal breast first, then they'll assess the breast that may have a mass or a lesion. You want to ask the female about any noticeable changes. Remember, we're trending. We're looking at changes from baseline. So have you noticed a change in the size, the texture, especially around the skin? We want to know about the discharge. Is it abnormal? Have you always had discharge? Is it more? Is there a different color, a different texture? We'll see a lot of, look at the clinical manifestations on the other side. Most cancers are usually single lump, single side, okay? Usually it's only on one side. I do know females who have had it on both sides. Usually it's much more aggressive if it's bilateral, very rare. You may see any spectrum of discharge. Bloody nipple discharge is probably the most scary, the most ominous, because as we discussed in Unit 1, the one thing about cancer is blood supply, abnormal bleeding, because it develops its own blood supply. Nipple retraction, okay, this is a little bit different from an inverted nipple. This is actually when it feels like someone's pulling on your nipple from the inside. I have some good pictures of that. Things we've already talked about in our review: the color, the feel of the skin, the changes with the nipple appearance. Even if you feel a sensation difference, if women say, I feel itching, or I feel a spot that's just numb, or it just doesn't feel the same when I touch it, sensation is different when I touch this other area. Those are all things we need to look into. Most breast cancers are not painful, but if they can be, it depends on how long they've been growing. It depends on what they've been pressing into. So you can have unilateral discomfort. Most of the time it's not painful. The reddened, inflamed, painful, rapid growth of mass, that is the inflammatory, that needs immediate attention, okay? They can become very itchy. So these are some clinical manifestations of a breast cancer. Here's one artist's rendition of a retraction. Here's an example of puckering, pulling in. The reason why this is an issue is because breast cancers tend to be attached to other areas, and when it's attached, then it pulls in on the ligaments in other areas of the breast. So it has a tendency to cause the breast to have an abnormal shape. Here is an inversion that is not necessarily cancerous, but I wanted you to see what it looked like. Here's a woman who's probably had a lot of fibroadenomas, who've had a lot of scar tissue. This is Paget's disease. It's a form of breast cancer that affects the nipple. And that's not something you would expect to see with cancer, but notice the discoloration, okay, and some texture differences. This is a raging inflammatory process that could be very much inflammatory breast cancer. This is not an easy one to see, but this is inflammatory breast cancer that shows, you don't see how bad it looks here, but you see some slight redness here. See how it's red around the nipple, and you've got a different color from this side? There's a fullness and there's redness. It needs to be investigated. Perfect nipple retraction and dimpling in this breast. It looks like somebody's got rubber bands attached to her and they're pulling it in. That's the breast cancer. Usually the cancer is fixed, and because it's fixed, it starts pulling in on these structures, and this is called classic breast cancer lesions. Okay, we're going to start, come back. You guys take a 10-minute break. We're going to come back at 9:30 and we're going to start with screening diagnostics, okay? That's what my alarm is for because I'm bad at breaks. So I'll see you at 9:30. Let's pause this recording. Okay, folks, I think it's time to get started. Is that all right? Okay, where we stopped was with the diagnostics. The most common and the thing you'll hear most about is mammography. We had some mammography questions on your homework. It's important to understand the barriers, the videos that I showed you guys that are regional specific, but those trends do match all over the country. Their findings match all over the country. So a lot of the barriers have to do with socioeconomic and belief systems. And we found even language. So do review those 2 very short videos. I think they're very helpful in understanding barriers to mammography. They do have their limitations. Mammography is not perfect. It is the best tool we have, but it does have an error rate. There are false positives. There are also false negatives. So you do need to understand that 10 to 15% of breast cancers cannot even be picked up by mammography. That's why we need the 3-pronged approach of clinical breast exam, of self-breast exam, and mammography together. So up to 15% cannot be seen. So they're not perfect. That we do have usually breast cancer is very slow growing. That it says it takes up to 10 years for a typical breast mass to become palpable. And palpable is a term that just means that we can feel it or touch it. So the smallest palpable mass is about 2 centimeters. Mammography can pick up a 0.5 centimeter mass. So 2 centimeters is about the size of a nickel. That's what we can feel. That's why mammography is so important, to catch it early. We talked about the directions of how to come in, how to prepare yourself beforehand. Calcifications are important to understand. Calcifications are usually the phone call that women get to say, would you come back in and have another mammogram, or we want to do an ultrasound, or we want to do an MRI. We see calcifications. Now it depends on the pattern, the woman's history, but usually when you see a cluster of calcifications, they want to do more tests. It could be benign, it could be another disease process, it could be calcifications within the blood system, the vessels themselves, because that would be peripheral vascular disease or atherosclerosis. That causes calcifications, but they need to be investigated. Usually clusters of calcifications are one of the earliest signs or one way that they do find cancer. So that is an alarm, something to need, we need to address. Macro calcifications, the slightly larger ones, are usually degenerative changes, and those can occur after the age of 50. Micro calcifications are a little smaller and can show even benign changes, one of these other disorders. Again, when they're clustered, we tend to have a little bit more of a concern about it. It doesn't mean absolutely cancer, but it can be a concern. So understand that. Other things we use are ultrasound. You see a woman here, the top picture shows a woman who is having a mammogram. That's exactly what it looks like. They squash it pretty tight. It's very uncomfortable, but it only lasts for a few seconds. So it shouldn't be enough pain to warrant someone not wanting to go. Very quick procedure. They're very efficient and they're very gentle and kind. The woman below, you see her having an ultrasound, and it's not uncomfortable at all. There might be some pressing and moving around on the breast, but what we're looking for here is fluid filled versus solid filled. Maybe the boundaries that it can show us. And what you see on the right of the person getting the ultrasound is what an ultrasound picture looks like. Black and white, grays, and people who read those are usually very good at it. The stereotactic breast biopsy is a biopsy under MRI or digital mammography. They'll use X-ray technology to guide the needle to the spot that they want to go. MRIs of the breast, these are just using the pictures are much more detailed. It looks like a cross section or actual dissection, so much more clear pictures. And these are indicated when mammography looks suspicious, but they can't conclude. Most biopsies are done with an MRI or digital mammography. Biopsies can be minimally invasive. They can take a very tiny syringe and pull out fluid, or it can be quite invasive and look like almost like a lumpectomy. So biopsies can have a very large spectrum of what those look like. Your follow-up treatment would be dependent on what type of biopsy you have. So I have some questions here, but I wanted to give you an opportunity to answer those with polling technology. Come down. Can you guys see the polling?
I do not.
Okay.
Oh, now I do.
Okay, so I'd like for you guys to answer these, I think, 5 questions. These are anonymous polls, so answer your questions and then I can show you the results. Hopefully I can figure out how to do that. Okay. I'm going to end the polling and share the results with you guys. So can you see the results?
Yes.
Yes.
Okay. So it looks like for the question number 1, many symptoms of breast cancer are the same as those found in benign disorders. 82% of you selected true. This is a true statement. Many of the symptoms are very similar to those found in benign disorders. Some of the signs that we see, especially with the retraction, those are the most differentiating. So that's why we have women come in and we do some ultrasounds and we do some further testing so we can have more objective data. Having 2 first-degree relatives with breast cancer significantly increases the risk for breast cancer. Absolutely, it does. Good job. The highest risk factors for breast health include early menarche, late menopause, and first pregnancy after the age of 30. So 54% of you said these are the highest risk factors, if you'll go back and look at your chart, these are low risk factors. The highest risk factors have to do with, and I've mentioned this earlier, the highest risk factor honestly is being female. It's being, it's aging. As we get older, our risk factors go way, way up. It's two first degree relatives. It's BRCA1, BRCA2, exposure to radiation. Those are your highest risk factors, okay? Not the hormonal stuff. The hormonal stuff is at the bottom of the list, and these are considered low risk factors. So, and it is important to know, oh, here we go. Number 4, most women who develop breast cancer have significant risk factors. Wow, 50-50. Most women who develop breast cancer do not have significant risk factors, okay? So they'll investigate, but no one in their family insignificant, most women. So, good job, guys. Any questions about that or challenges on those, on the answers to those questions? Okay. Let's talk more about diagnostics. We talked about mammography, ultrasound, MRI. The other diagnostic thing we need to consider is axillary node involvement. This is super important. This helps direct what we're going to do about the cancer. Typically, 4 or more positive nodes, 4+ positive nodes, shows an increased risk of cancer recurrence. So that number 4 is a game changer. We want to see less than that. If we see more than that, then they're probably going to do more aggressive treatment. The number of nodes involves, again, it assists in the treatment choices. Lymphatic mapping and sentinel node dissection replaces what we used to do, which was a full axillary node dissection. And that's when they would take 30, 50 or more of your axillary nodes. And if you can see the picture up in the right-hand corner, it shows injecting dye. And they'll inject the dye around the cancer, and all of the lymph nodes in your breast, and there's a ton, flow to the axillary area. So, and you can see, you know, dozens of lymph nodes. So rather than to take all of those and compromise our client for the future, they now are looking to where does the dye in that area flow, and the 1 or 2 nodes that that dye flows to, those are called hot nodes or sentinel nodes. If those, they'll take those. If those are positive for cancer, then they'll take a bunch of other nodes. If they're not positive for cancer, then they won't have to take all the ones that are downstream. This video that I have, you have that also in your in your module. Look around the minute of 2.35. If you'll fast forward, it'll show you what that sentinel lymph node looks like. Beautiful animation, and only takes about 15 seconds. So do look at that to help you understand what sentinel lymph node biopsy looks like. The care of a patient with lymph node biopsies are very similar to lymph node biopsies post-mastectomy. This is the same care. And the idea is if you have axillary node dissection, which means a lot of lymph nodes are going to be taken out. If a lot of lymph nodes are taken, you are at risk for lymphedema. Everything you see here and everything we're going to talk about after surgery are ways to prevent lymphedema, okay? These are things you would teach your client to do at home. These are, if you have a dissection, which is where a lot or all of those axillary lymph nodes are removed. These are indicated, lymph node biopsies are indicated. This might be the only symptom you have, or you might have an enlarged lymph node or a lump in your armpit, okay? So the metastasis site, which are your lymph nodes, are giving you more symptoms than the breast cancer itself. So if you have palpable nodes, they're touchable. If you have a late stage of cancer, then they're going to want to remove and do those and do a lymph node dissection. The ALND is an axillary lymph node dissection. That's what that stands for. So if you have to have this done, longer recovery, more complications. In the future, after you get a lymph node dissection, that's when you'll see the signs that there's no blood pressures, injections, or blood draws in the affected arm. And we'll see prevention and treatment of lymphadenopathies and lymphodemas, okay? What you see here, you have to protect that arm. Remember, the lymph nodes help drain fluid. They also help protect us against infection. Use an electric razor, sunscreen, bug spray, gloves when you're gardening. Any injury to that affected side, that arm, you could have difficulty healing from infection or healing because you don't have the lymph nodes in there to help you with infection. So look at these instructions. If you did get a scrape, use antibiotic ointment. Call a doctor if you have increased signs of infection. It's going to be harder to manage. These are with people that have had a lymph node dissection. So classifications of breast cancer. Everything you see in the purple are things we've talked about before. Use the TNM status and the tumor differentiation, how to grade. Those are equally important if we're talking about breast cancer and how to classify. Above and beyond TNM and tumor differentiation, we have what we call estrogen, progesterone, and HER2 receptor status. These are big in deciding what our treatment is going to be. These are either positive or negative. We also see oncotype diagnoses and mammoprints. We're seeing more and more genetic profiling. We've identified, besides BRCA1 and BRCA2, another genetic defect that is related to breast cancer. Not as commonly known yet, but this is also going to be part of the mapping to try to figure out which chemotherapy or which treatment is best. So all of these determine what the prognosis is. We're going to spend some time on responses to hormones. You will need to know that receptor positive tumors, hormone receptor positive tumors, and that's with estrogen and progesterone. If you're hormone receptor positive, you're going to have a more positive outcome. There's a play on the positive to help you remember. Positive tumors have a more positive outcome. Look at the character of the cells. They're more well differentiated. Remember, the better differentiated, the better the outcome, the more it looks like it's original cell. Diploid DNA, that means it's two-strand. That's what they're supposed to look like. They have a lower chance of recurrence. They're more often found postmenopausal as we're older. And they're responsive to hormone therapy. Receptor negative tumors, these are more dangerous tumors. Remember, poorly differentiated means they're sicker cells. Aneuploidy DNA means it's not double. It's either a single or it's more 3 or more, which are diseased abnormal DNA structures. These are the ones that are harder to put into remission. It comes back. They don't respond to hormone therapy. These are more often found in premenopausal women, younger women who have a more aggressive cancer. Okay, so that's why it's so important to understand whether and put as part of the profile whether these cancers are hormone receptor positive or negative. Additional diagnostics, we want to look at labs, liver enzymes, the calcium and the alkaline. These are showing us, is the liver diseased? Are the bones diseased? We're looking for metastasis. The imaging will also show if we've had metastasis beyond the lymph nodes. Okay, so these are further diagnostic tests. And this kind of addresses your question, Travis, on why does it matter? Why do those drugs, why is blocking those receptor sites important? And that's because if we've got a hormone receptor positive cancer, and that's basically saying that the cancer is being fed by hormones. If we stop feeding the hormones, then we have a treatment for the cancer. We stop feeding it, it'll die. So that's why if we block those receptor sites with fake hormones like SERMs, then we have an avenue to treat the cancer. So treatment. This is starting. Any questions with diagnostics so far? Anything we've talked about to this point? Okay, so with treatments, neoadjuvant therapy, you probably heard before. This just means that it's not our primary treatment, but it might be first. This is when you have a very aggressive cancer and they may want to actually shrink it before they go in and do surgery because the surgery will be more successful. So you may see chemo radiation before the primary surgery. Surgery is usually the primary. This link is the same, I believe, as the one that you see earlier. It gives you all kinds of illustrations of what the different surgeries look like. It's a great short video. We see lumpectomies, which is breast conservation. We see a mastectomy or a radical mastectomy. Mastectomies can be very simple and where they just take the, simple is where they just take the breast tissue. And the radical is where they take the breast tissue and the muscle underneath. And that's what I used to see when I first started nursing. Any type of breast cancer had a radical mastectomy because they didn't really understand fully how it spread. They felt that it spread more and to the adjacent tissue, so they would take everything down to the muscle. It was very disfiguring and very aggressive. So we see more lumpectomies and simple mastectomies these days. Breast reconstruction is another thing we see more and more to restore the appearance if they have a mastectomy. So we see neoadjuvant surgical. Adjuvant therapy is beyond the primary, which is usually surgery, get rid of the tissue. They're going to add radiation, chemo, hormone therapy, and maybe bone marrow and stem cell transplant. Now, if you have radiation therapy, if you have a lumpectomy, you 99.9% of the chance will always have radiation. The reason why we've moved from every patient getting a radical mastectomy to allowing lumpectomies is the fear was if you leave behind any tissue, there could be hidden cells, hidden cancer cells. So with a lumpectomy, the way around that is to provide radiation therapy with a lumpectomy. That way we can eradicate any cells that are remaining and we are much less disfiguring and the healing process is much faster. Chemo, the same thing. We see chemo added when it becomes systemic. So if you have systemic disease, we're going to want a drug that goes throughout the whole body system to be added. Systemic disease is when it metastasizes. Even to the lymph nodes, that's considered metastasis, local mets. Hormone therapy, if it's hormone receptor positive, you'll add hormone therapy. If it's negative, there's no need for hormone therapy. The bone marrow and stem cell transplant is when you have recurrent disease and you're trying to fight the disease. We'll add bone marrow and stem cell transplant. This is so we can be really, really aggressive with chemo. And then the bone marrow and stem cell is a rescue method. Okay. CAMs stand for, that's complementary and alternative medicine or therapies. Okay. CAM, that's medicine, but it's the same thing. These are things like acupuncture, herbal remedies, homeopathics. These are things that may very well boost a person's outlook. It may boost their immune system. It may give them some value to add to the whole treatment. We ask our patients to and support our patients in their holistic care. We ask them to add these therapies, but not just use these therapies alone. Research has shown that these therapies alone do not increase, save lives and increase survival rates. So let's talk about surgical treatment. The video shows the different surgeries and explains the different types. There's also a figure in the book that shows the different types of surgery. The lumpectomy, breast conservation. These are for smaller tumors with the cancerous tissue, plus we want a border of normal tissue. We don't want to have to take an excision send it to the lab and the borders show that there's cancer. If there's cancer in the borders, that means there's been cancer left behind. So we want to take a wide enough excision to where there's normal tissue on the borders. To have a lumpectomy, you can only have minimal nodal involvement. If there's a lot of nodes, they're going to want to do a full mastectomy because it's not going to be aggressive enough to treat the cancer. You're going to want someone with larger breasts to have a lumpectomy. If you have small-breasted women, a lumpectomy could be more disfiguring. You have a better chance to have a full mastectomy and reconstructive surgery. Some contraindications to lumpectomy is if you have multicentric disease, which means you've got cancer in more than one quadrant or one location. If you have positive margins, if you've ever had a history of radiation, because if you've had a history of radiation before, radiation is necessary for lumpectomies and they don't recommend you get it again and again and again. A history of this little abbreviation stands for collagen vascular disease. Those are things like lupus and those autoimmune disorders we talked about. So the collagen vascular diseases will leave you, and the medications that you are on, those are comorbidities that won't fit well with having a lumpectomy, and that's because, again, of the radiation you'll need. So the 5 to 7 weeks of radiation after, we've already discussed why, micro disease, cellular disease that might still be hanging around. The outcome, folks, for a lumpectomy followed by radiation has the same long-term survival rate as a full mastectomy, okay? So when they first started doing this, people weren't comfortable because they thought it would come back, but the same long-term survival rate is both. And it's important to have that knowledge when you're teaching your clients. Here are some pictures of lumpectomies after. You'll see the scar in the outer quadrant of the top left, and the top right, you'll see, again, it's the outer left quadrant. That's a fairly new scar. And it says here that they've had it on both sides, but I can't see the other side very well. You will see scar tissue on the female in the lower left, and under the crease in the bottom of this one patient, there's a scar there that's going to be barely noticeable. The lower right-hand picture that you see has an axillary node dissection. So this person probably had a lumpectomy in the area of the axillary. And when you see you'll see a pretty large incision there. This person probably had more axillary nodes taken. This person just had their surgery. You can see staples and you can also see drains. Even with lumpectomies, the patient will go home with drains in place. So how do you care for a patient who's had a mastectomy? In the old days, I remember caring for patients who had a mastectomy. They were in the hospital anywhere from 3 to 5 days. Now we have drive-through mastectomies. They aren't in the hospital overnight for the most part. Lumpectomies and even mastectomies, they could go home depending on certain factors. So preoperatively is very important. During a preoperative visit, we need to make sure that we have psychologically prepared them for what they're going to see. When we have something disfiguring, that's disfiguring, it's a huge impact to your self-image, especially if it's a sexual disfiguring. So there's a lot of things we need to consider with these women. The younger the woman, the more disfiguring they're going to feel. Okay, so psychological preparation, explaining to them what they're going to see afterwards, prepare them as best you can so that there's to decrease the shock factor. Therapeutic communication, give them an opportunity to express themselves and express their fears. Every woman who has a lump or has to go back in will hear from their friends and their friends these horror stories. So there's a lot of misconceptions that they're going to be carrying with them. We need to hear those and we need to correct those misconceptions. And those aren't because of any ill will. it's because someone had an experience that was very individual to them and their cancer. And it doesn't apply to every person. So we have to let them know that this is you, this is your disease process, and it's going to look very different. We need to teach them again on what to expect. There are going to be drainage tubes. Where is the incision going to be? What's it going to look like? Most of them are profoundly surprised by their mobility restrictions, how uncomfortable it is to raise their arm, move their shoulders, reach across, and do their normal activities of daily living. Using that arm is going to be very uncomfortable with even a lumpectomy. So they are going to have some mobility restrictions. The length of stay if they're in the hospital. So we need to tell them exactly, this is what we should expect to see. Reach to Recovery is a program for breast cancer patients. People who have survived breast cancer, who have gone through the surgery, the radiation, the chemo, have become volunteers to go and talk to patients who are facing exactly what they went through. And to see someone who looks amazing, who is a 5-year survivor, who has gone through all of these things and come out the other side looking amazing, is just what these patients need to see. So you should see if you have a chapter, a local chapter of Reach to Recovery. Look Good, Feel Better is another agency that we talked about, I think, in Unit 1. It's if you're going through chemo and you lose your hair or radiation, when you look good, you feel better. You psychologically feel better. It shows them wigs, places to find wigs, turbans, a way to style yourself up a little bit, even how to put makeup on to make yourself look as good as possible. And it just gives you a little boost of your self-esteem. So those are agencies that are very therapeutic. Post-operatively, folks, don't forget your basics on post-operative care. You're going to prioritize according to your ABCs, so airway, breathing, circulation, and pain. Pain is the 5th vital sign. You're going to want to be thinking about all the things you do with a post-op patient with preventing complications of pneumonia, DVTs, infection, constipation from pain medications. That's traditional post-operative care. We're going to go into some specific complications soon, but there's also a chart in your book. So post-operative care with drains. Most patients are going to have drains. Here's some illustrations. There's some actual drains here for you. These are Jackson Pratts. Hopefully most of you saw them on your Nursing 111, maybe 121. So fresh post-operative, it's important for you to know that, and the patients, that when they come out of surgery, fresh post-op, that's going to look like frank blood, because it probably will be. It's going to be mostly bright red and bloody. They can have up to 200 milliliters within that first 24 hours. That's not unusual. What you should see is the trend, that it'll gradually lessen. It will become serosanguinous, which is that pink lemonade looking color, to eventually a serous color, which is what you see in this picture. By day 2, you should be cutting that drainage in half, okay? These are removed when there's less than or equal to 30 milliliters per day per drain, or if there's signs and symptoms of infection. So some women get these out within 7 to 10 days, but a lot of, I've gone online and looked at some testimonies. Some women will continue to have drainage above the 30 milliliters for a 2nd week into a 3rd week, and they get very distraught because they want these drains to come out. So that's our criteria, is less, you might see 25, but usually it's 25 to 30 per day per drain. If they show signs and symptoms of infection, they have a fever or malaise, or locally they're red tenderness, these drains need to come out. We're going to have to deal with a ABD pad that might have to be changed a couple times a day. But we're not going to leave these foreign tubes in our body if we're showing signs of infection. So complications with post-op drains. You might see a sudden increase or decrease. If you see a sudden decrease, it's probably a blockage. We strip these, or we may have to flush them or call the physician. So if there's a sudden increase, there may be a pocket. If it's red, there may be some bleeding. So we'll have to discern how much of an increase, how bad does this look, and we'll have to notify the provider. If they're like the changing color to red, or if it's clarity, if it becomes cloudy, that may be showing a sign of infection. If there's an odor, we're looking at infection, and we've already discussed the occlusion. So those are some complications that can come from a patient, or if you're caring for a patient in the hospital, things you need to look for with the drains, and then what we teach them at home to look for with the drains. Okay, post-op care, positioning and movement. A patient needs to have, that's had a lumpectomy or a full mastectomy, they need to have their head bed 30 degrees elevated. The affected arm must be elevated, okay? The drains need to be free, not occluded, not bent, not squeezed, kinked. We need them to be flowing, get that fluid out of their breast. We need to support their arm while they're initially ambulating. Usually the first 24 hours, we'll have them hold their arm or have it supported. And then after 48 hours, we can allow their arm to hang straight by the side. We need to initiate some isometric exercises. Isometric exercises look like squeezing a tennis ball or a washcloth or something. Squeeze and release. Those can be started the day of surgery. They come home from surgery, within a few hours, we start those isometric exercises. Then we want to graduate to maybe arm bending, bending at the elbow. And that again can be done on the same post-op day, just bending at the elbow. So things by the next day, they can do the bending at the elbow. They can brush their hair, brush their teeth, wash their face. What we don't want to see a lot of is movement in that shoulder. We want to keep those shoulders fairly still initially. Once we get the tubes out, then we can progress to a higher level of exercises. The book shows some pulleys. The reason why we use a pulley system where they can use a towel or a rope, they hold on to it, is because they can take their good arm while holding a towel, maybe behind you, like you're drying your back. Your good arm helps lift up your bad arm. Okay, so you're using the strength of a pulley system to lift your weaker arm, your affected arm, and help start those stretching exercises. So some complications that can occur from having surgery, breast surgery: lymphedema, fibrosis, the pain and paraesthesis, infection, and impaired mobility. So let's talk about these a little more specifically. Lymphedema, that's probably the one we're most concerned about because it can be rather disfiguring. This prevention, usually this is with the care of a mastectomy patient. They're in the hospital. These are when you've had a full axillary node dissection. Nursing, you're going to put that sign above the bed. It's probably one of your most important moves because first, do no harm. You do not want to put your patient at risk for harm because somebody comes along and takes a blood pressure and then just damages the patient's arm forever and ever. So no blood pressures, venipunctures, or injections on the affected side. There's a sign that needs to go above the bed so that doesn't happen. Keep that arm elevated, and it needs to be above the heart. Elevate the hand above the heart so that you can have adequate drainage. We need the help of gravity since those lymph nodes are gone. As we teach them to protect that arm for minor trauma or sunburn. They have to wear those gloves and mitts when they're gardening, sunscreening like the previous picture, long mitts when they're taking things out of the oven or when they're cooking. It's going to take it longer to heal, and we're at higher risk for infection because those lymph nodes are gone. It's a good idea to have that MedAlert bracelet on if they were to become injured, come back into the system that says this patient should have no venipunctures or blood pressures on whichever side that they've had their mastectomy. If they do experience acute lymphedema, We want to make sure that we elevate the arm a little higher. We may want to increase those isometric exercises. We might want to add diuretics. A manual massage to try to actually massage the fluid toward the axilla and toward, so it can be dumped back into the circulatory system. There are intermittent pneumatic compression sleeves that you can put on a patient's arm, and we'll have a picture of that shortly. Once you've had a mastectomy, for now, this is a lifelong practice that these patients have to implement. They always have to avoid the trauma to the arm. They always have to avoid blood pressures and venipunctures to that side. If a patient has a bilateral mastectomy, often we'll use the legs for blood pressures, but at that point, you just have to choose the worst of two evils when it comes to starting IVs or doing venipunctures. We don't have a choice, but if somebody has a mastectomy and then 5 years later they have a new mastectomy, then you're going to use the older arm or the older side because that's had more time to heal. So look at your nursing safety. One of the things that I wanted to point out with this action alert, and I don't know if I changed these page numbers or not, but one of the action alerts is people that use acupuncture as a therapy. Acupuncture has been very therapeutic for some people in their problems. The affected arm cannot have acupuncture because that's a form of a needle stick and can cause trauma that will be a long time in healing. So here's just an illustration of an elevating your arm above the heart, no venipunctures or blood pressures. You see a picture of a pneumatic sleeve, isometric exercises, and this is an actual patient with lymphedema. This is what it looks like. Patients can have permanent lymphedema. If this is not treated, prevented or treated aggressively, this patient could have this huge arm compared to her small arm for the rest of her life. And I've seen this before. I've seen a significantly larger arm on a patient because of this complication. Do we have any questions on lymphedema at this point?
I do.
Okay.
So with the impaired mobility, so some people are always going to have it and some people can come back from it. Is that what you're saying? Like if they do the right physical therapy, then I don't want to say normal, but will they become more normal or will they always have that impaired mobility?
Okay, we're gonna, I'm actually gonna get into that a little deeper right now with this slide. So can we discuss, and I'll answer that question when I get to the bottom of this. Is that okay?
Yeah, that's fine. Thank you.
Sure. So the other thing we're talking about is the risk for impaired mobility. We discussed early how important it was to start those post-op exercises soon. Again, women are surprised at how limiting. It's like, wow, I didn't expect that lumpectomy to make my arm or make me feel like this is so uncomfortable. So they may want to guard that and not start their exercises. So remember, initially we start on things that do not stretch the shoulder or stress the incision, those isometric exercises. Eventually we're going to do those shoulder stretches. There's something called hand wall climbing, and we teach the patients to put their hands on the wall and move them up. Again, we're using the support of the wall to help them raise their arm up rather than just doing a blind trying to raise their arm up, giving them some support. The pulley exercises. Progress is very individualized. It depends on how aggressive this the surgery is, and it depends on when those drains come out. So most women recover without any, with minimal issues with mobility. What they do have is, and they also have changes in sensation. They'll have the numbness, tingling, tightness, and pulling. They can have it down the side, kind of into the abdomen and stretching into the back. They may feel like a numbness or tingling sensation because of the nerves that have been involved or cut. Most of this will all go away and resolve. Most impaired mobilities, usually there's not, I haven't heard of many cases where there's a permanent
mobility issue. And this may just be a complication from an infection, maybe a nerve that's been cut, but that's very rare. The risk for impaired mobility is when patients don't get their exercises started, so it takes them a longer amount of time to kind of work out that stiffness. It's like somebody having orthopedic surgery and they don't do their rehab. It takes them a really long time to get back to normal. Does that help answer your question, Amanda?
Yes, it does. Thank you.
Okay.
A question.
Okay.
For the changes in sensation, is that normal for them to feel that, or would that be some type of sign that we would know that something is going wrong?
It is a normal side effect that they have numbness, tingling, and tightness. So any type of neuro thing, I mean, we would inspect for sure, but we would prepare them and say, you may feel numbness and tingling for up to 6 months after your surgery. Most of this will resolve. This should usually resolve. And then after the 6 months, we monitor that to see, they may have some permanent numbness or tingling, but that is something that we would not consider as a traumatic side effect. It's just one of those side effects that they have to deal with. But yeah, we would expect that. And we would also expect it to resolve. Okay. Even after a lumpectomy or even a full mastectomy, you would encourage your clients to do their self-breast exams, their clinical breast exams, and their mammography. And they would be, of course, on surveillance mode. You would want them to have the higher frequency. Once you've had breast cancer, you're at much higher risk to have it again. So these would be on surveillance mode very frequently, and probably more frequently initially, and then as time moves on, then they would back off on that. So I am going to ask you guys to take a 10-minute break. We will come back at, let's see, at 10:15. How about 10:25? And then we'll spend 20 more minutes in class, and you guys will have another break before we start our exam review. Okay? So take a break and move around. Okay, folks, we only have about not even 20 minutes to finish up. So or actually about 20 minutes. So let's move forward and discuss another complication of surgery, which is a hematoma. Hematomas is essentially post-operative bleeding, but it's encapsulated into a small tumor or pocket. This usually occurs within 12 hours of surgery, when you're most likely to bleed at any time within 12 to 24 hours of surgery. So these hematomas usually occur within 12. We want to be watching and assessing our patients for swelling, tightness, pain, bruising. If they have more drainage into their JP, more bloody drainage, that could be a sign that there's some bleeding. Sometimes we can see a blocked drain, so that will cause a hematoma to build up, or a seroma to build up in the breast. So we're really going to need to pay attention to that dressing. You don't want to remove the dressing, but you can palpate around the dressing, below it, above it, to see if you notice any tightening or changes. And within the first 12 hours of surgery, you should be assessing that patient when they come to your unit, and at least every 2 hours, to see if there's any changes. So that is a hematoma. You may see changes in their vital signs. Hopefully they would have enough pain and tightness that you would catch it before they had significant blood loss. You will want to notify the surgeon. They may actually need to go back in and cauterize something. Another situation is a seroma, and a seroma is very similar to a hematoma, but instead of blood, it's serous fluid that's leaking. If those, the lymphatic system has been affected, or the lymph nodes have been removed, there's another vascular system, if you will, with fluid has a lot of serous fluid, and that can create a pocket. You'll see the lower picture. Of course, this patient has a reasonably healed wound, but has developed a pocket of fluid over time that looks like it has never been addressed. So this can be under the incision. It can be, gravity will carry it to the lowest point, so it may slip under the axillary area. They will have the same tightness, swelling, heaviness. They may even hear that as they walk or move, they could hear that fluid sloshing around inside. When the drains are clogged and can't be, the fluid can't flow, or if the drains are removed too early, we might see a seroma. Sometimes they just occur no matter what we do. They'll provide, if the drains are still in place, of course, we're going to try to unclog that drain through stripping or maybe through flushing. They can also very easily aspirate that fluid. Just take a needle in and just pull it off, keep pulling it off until we shrink the edema and the swelling. So breast reconstruction, let's talk a little bit about that. Breast reconstruction. So there's two main types. The most common for breast reconstruction surgery are implants. Typically, they can be done at the exact same time of the surgery itself, or they can be done at a later date. And for every patient, that is a decision. There are a lot of factors that go into that decision. So that's up to the patient and their provider as to whether that's a good decision to have right away. So you'll see the before and after picture of a full mastectomy and then reconstruction. You see the how they do this is they put an expander in, a tissue expander, and a tube. They fill it up and they stretch the skin. They have to expand the skin on the outside, and the skin will expand, just like when a woman has a baby and her tummy gets a lot bigger to cover her growing uterus and fetus. Skin will expand. Depending on your patient and other issues, I happen to know, personally know a friend who had breast cancer, and her skin would not expand well. It got very thin and she was not able to accept an implant. So they had to use another method. So we have to be careful about how far we expand, what's acceptable size-wise. So you'll see the diagram about how they'll expand, then they'll go into surgery, take out the expander and put the implant in. Once you have an implant, you'll need to click on this YouTube video. When they have an implant, they have to do some specific exercises so that they don't get encapsulation. You have two pictures here of encapsulation, and the lower left-hand corner shows she had bilateral. That one, because of scar tissue, once you put the implant in, scar tissue will develop anytime you have surgery. And you have to do exercises to move that implant around in that cavity so that it doesn't encapsulate and cause a protrusion or a malformation. And you can see encapsulation on the one patient. It's kind of pushed the implant upward, so she's got a lopsided appearance. On the lower right-hand corner, we see some encapsulation where it has forced the breast tissue downward. So it's rather disfiguring. So there are exercises that they're encouraged to do. Basically, they're pushing that implant to the far left, to the far right, up and down to create a pocket to prevent scar tissues from shoving their implant into a weird direction. With breast reconstructive surgery, is very similar to any type of breast surgery. You're going to have the same tenderness and mobility, exercise issues as before. You won't have the same issues with lymphedema because it's not going to be affecting any lymph nodes. The tram flap procedure is the other method that we can use for breast reconstruction. Rather than using an implant, this uses a woman's natural tissue. So they're taking tissue on their own body, it's autologous. They're moving it from either their back, their buttocks, or their tummy, and they basically take that and it's like a transplant, if you will. The neat thing about this is that they're able to, rather than cutting the blood supply, they try to maneuver it so that it's not completely cut. Some of the vessels will be cut. So they're trying to move this and navigate it toward the breast. Of course, the skin will be completely cut and moved away. The fat will be and muscle will be completely cut and transplanted, but they are trying to maneuver some of the blood supply underneath. This does take a longer recovery time because you have a donor site incision, and then you have the recipient site incision on the same person. So you have to do all the surgical maneuvers that you did before, incentive spirometry, the DVT prevention, so all the things you would do normally. And then you have to add a few things specific to this surgery. Like that head of bed needs to be elevated. The knees need to be flexed, especially if this is on the abdomen. You don't want to put any tension on the donor site. And you want to have that skin, because you've taken away skin and muscle tissue. So if you stretch it, you can imagine stretching that apart, and it may be popping apart. So you want that almost like fetal position if it's tummy. You want that tissue to have some no tension on that tissue side. If you have it in the buttocks, bending your knees is going to cause that to stretch. So you would want those knees to be more straightened. So it depends on whether that incision is. Where I've seen it most is on the tummy. So these women have come back from surgery with breast augmentation plus a tummy tuck. So we have this big long incision on the bottom. We have no high impact exercises or lifting for 6 to 8 weeks. They need to understand both whether they have the implants or the tram flap, that they're not going to look okay initially. So when they come out of surgery, there's a lot of healing and a swelling and that needs to take place. It could take up to 6 months for us to have the optimal appearance that we're looking for. And we tell them that ahead of time so they don't think that it's a failed procedure. Here's some diagrams on the tram flap showing the different donor sites. The transverse rectus abdominis is the one I personally have seen. And this is, again, is your tummy tuck along with the breast augmentation. The videos that I showed you before, there's a couple of links, shows are really good. This one's harder to visualize to me, but if you look at the video, it'll show you how that's done. They show all the different types. So post-op care, remember we have more than one incision site. So we have to look at the breast and make sure that the incision or the new flap and the donor is actually perfusing well. If you've ever taken care of a patient that's had a skin graft, we basically have skin and tissue graft. That may not take. Your chart shows things to watch for, but if you've got a dusky cyanotic area of skin on the breast, that's not good. That's showing that there's a lack of tissue perfusion. So you're going to do neurovascular checks to that donor site on the breast. You also need to look at the, not the donor site, the recipient site. You also want to go to look back on the donor site and just make sure that it's healing well and looking for signs and symptoms of infection. Again, if they have implants, they need to be doing their breast massage exercises. Discharge instructions for our chart 74. Folks, whenever it comes to teaching your patients what to look for at home, you need to know those. You need to look in your book. This tells the do's and don'ts of a patient who's had surgery, especially breast implants. You especially want to be careful with restricting circulation to the chest with your tram flap procedures. That chart is going to give you specifics on what that looks like to tell your patient. So please look at that chart. I said that 3 times. Okay.
There was a question from Maddie. She said, what does rejection of an implant look like?
What a rejection of an implant. People who have augmentation get rejections all the time. They could have pain, they could have disfiguration, they could have there's ruptures, there's all I would imagine the biggest things are discomfort and disfiguration. That's a true rejection. With the encapsulation, that's going to take time because that's scar tissue that's developing, and that develops over time. That's what the exercises are for, to prevent that. Does that help?
Yes, it does. Thank you.
Okay. For radiation therapy, let's go into some adjuvant therapies. Radiation therapy is the most common because with breast conservation therapy, we have to, if we're only going to take a lump, then we have to treat the remainder of that breast to make sure there's no microscopic disease. So they do the whole, with whole breast irradiation, which has been traditional. They do external beam radiation daily for 5 to 6 weeks. And it's usually daily, Monday through Friday. We're getting more advanced. They're coming up with new techniques and strategies. There's something now called partial breast irradiation. And that's when they use higher dose brachytherapy, which means they're taking objects that are saturated with radiation, and they're putting inside the breast right at the site of the tumor. And it's a higher dose, more locally involved. So they're not having to pass through as much normal tissue. This is a lot shorter therapy. It could last hours to days. Okay, there are 3 different types, but just know that whole breast radiation, or they call it irradiation, is traditional over 6 weeks, external. There are newer types that patients may be having that they go in, they get either, they have a tube that they get something inserted, something small inserted. It's in there for maybe an hour and then they take it out. Or they have something larger that's inserted and then they take it out. And that speeds up the treatment process to where you might have your radiation finished in 5 days. Lots of new things on the horizon. Okay, while the radiation is in the body, while that source is in the body, that your patient is radioactive. As soon as they take it out of the body, the patient is not radioactive. To my knowledge, there are no implants that a woman has, that a radiation implant, brachytherapy, that is left in her body where she goes home and then she has to be on radiation precautions. We do have that with prostate, but I don't know, to my knowledge, that is not available yet in breast radiation therapy. Palliative therapy. Sometimes we see radiation therapy done just for palliative care. The whole breast and partial breast irradiation is part of a cure. It's a plan for cure. Palliative, this is usually done just external, and that's shrinking any tumor enough to keep someone more comfortable or to enhance their quality of life, or maybe buy them a little more time. But they need to understand that it's palliative and not curative. Besides radiation, we have drug therapy. Chemotherapy is usually your anti-neoplastics. Biologics are getting higher on the list for these, but these are usually 4 to 6 cycles. If you have any nodal involvement, chances are, or distant mets, of course, you're going to have some type of chemotherapy. If you're estrogen receptor negative or progesterone receptor negative, usually you have a more aggressive cancer, and they're going to recommend some type of chemotherapy, anti-neoplastics. Another drug on the list is hormonal therapy. Again, estrogen or progesterone receptor positive is what you have to be eligible for hormonal therapy. Targeted therapy is the dream of cancer care, and that's when you have some type of marker on your cancer cell and you have a drug that goes directly to that marker and can kill only the cancer. We do have more and more targeted therapies, And the first targeted therapy was actually for breast cancer, and that was with our HER2/neu, and we talked about that in Unit 1. That is, if you have the HER2/neu positive marker on your cancer, we have a drug that will attack that, which is it's a good thing. Stem cell transplant, again, that's the rescue therapy. We may see that added to our regimen, depending on how aggressive the cancer is. Let's talk briefly of hormone therapy, because this is one of the areas you will really see it used. The SERMs that we talked about before, sometimes we treat those patients who are high risk that have the LCIS and the hyperplasia, BRCA1, BRCA2. I gave you guys a list. They might go on these SERMs. And the two that are most popular are your tamoxifen and your feresteron. Then we have the Foslodex as well. These are all different types of hormone therapies, okay? They either block the estrogen from going in, they either destroy the estrogen receptors, they do something to keep us from feeding the cancer the hormones that they need to survive, okay? So these are some drugs. Look over the side effects, look over the risk factors. There's only a few. I'm only going to give you the top 2 or 3 drugs on each of these. So look these over, because when we ask you drug questions, a lot of that has to do with which drug is most appropriate and what side effects do we need to look for. Nurses need to know what safety parameters to watch for. Here's the issue with the targeted therapy that we've already discussed. The trastuzumab, which is the Herceptin. That's for the HER2/neu. It's a pretty aggressive drug. Look at the capillary, anaphylaxis, capillary leak syndrome, liver disease. So these are cardiac dysfunction. So these are some things that we have to be concerned about. Okay, so overall, your anticipated outcomes, what we hope to achieve with any type of breast disease, and specifically with breast cancer and treatment, is we want to make sure with that pre-office visit that we reduce their anxiety, help with their coping, and help them experience their grief, their loss regarding their wellness, and their physical changes. We want to maintain their personal dignity with privacy and care in our own reactions to a disfiguring scar. Once they've had treatment, remember that ABCs is priority, but we want to manage their pain, their mobility, prevent that edema, especially that lymphedema, and help them to restore the most optimum level of cosmetic appearance. And again, that's going to be depending on their needs. Okay. I do have another set of polls that I'm going to try to get to. Maybe. Here we go. Let's do a few other questions. I'm going to share this and give you an opportunity to ask a few more questions before we close. There's 3 questions if you guys will answer those.
Okay, let's share the results of what we have here. So just a quick review. What characteristic of a breast lump or mass is more associated with breast cancer than benign disease? So we're looking at something more associated with breast cancer. Attached firmly to the chest wall is the one that is most associated with breast cancer. Remember, we talked about how symptoms, a lot of these can look similar to breast cancer. Most cancers, lump or mass present in the same area of both breasts, that's most likely going to be fibrocystic or something that's benign. Pain or discomfort caused by palpation. Usually breast cancers are not painful. The most, which more associated, the number one thing is attached firmly to the chest wall. That's the one characteristic that is most associated with cancer. All the others that we talked about were freely movable. So, and with the appear suddenly, most cancers take a while. Remember, we said about 10 years to grow to a palpable size. So most cancers are slow growing. What age does the American Cancer Society recommend that women begin self-breast exams? They recommend it starting at the age of 20. At the onset of menarche, when girls start their periods, their breasts may or may not be developed to the point that they can start self-breast exams. There's still a lot of growth and changes going on. Unilateral breast drainage after menopause should be referred immediately to the healthcare provider. This is a true statement. Any changes after menopause, which we'll talk more about tomorrow, remember, whatever the baseline is, whatever your baseline is, that's you don't want to see trends beyond your baseline. If you have one-sided breast drainage after menopause, one side is usually a little scarier than two-sided. If it's after menopause, then this is a change in your baseline. So for two reasons that should be referred, and you're aging. So those are some reasons why it would be wise to be referred immediately to a healthcare provider. Okay, do we have any questions at all based on this material that I haven't already addressed?
Could you explain the treatment again for bone marrow and stem cell transplantation, just briefly?
We're not going to go into the treatment for that in this content. If you want to go into the treatment of bone marrow and stem cell, that's way back in Unit 1. You and I can Zoom and I can review it with you, but I don't want to take time out for that because I am not going to go into the details of that for you guys.
All right, thank you.
But I'll be happy to talk with you about it, Travis. I just wanted you guys to know that it was an option of the whole gamut.
Gotcha, thanks.
You get touch base with me if you want to chat about it, okay?
Will do.
And what were you saying about the medications?
Can you be more specific?
Specifically about the serums, SERMs.
About the SERMs?
Mm-hmm.
We went up to this one slide to talk about hormone therapy. So I said it would be, you know, I usually only focus on the top couple because you guys just have too much to cram into your brains with all this content. It is important for you to understand the side effects. As RNs, we need to know the safety parameters. Which patients we talked about which patients may not be a good candidate for this. We need to be able to recognize and teach our patients who might go on tamoxifen what to look for as far as normal side effects or what to look for dangerous side effects. Is that what you're referring to?
Yes, ma'am. Thank you.
Okay. Any other questions before you guys have your test review? If you do, post them on, you can contact me, but if you want to post them on the discussion, I'll be happy to look over them and address them, okay?
Thanks for coming to class, you guys. And I'll see you guys in a few minutes for your test review.
Thank you.
All right, thank you.
Take care.